It's already been alluded to in some of the talks, but I want to bring some focus to the issue of Medicare paying for services that are not beneficial to the patient. The whole concept of palliative chemotherapy, I think, needs to be examined. Is it really palliative at all? And related to that is putting in an implantable defibrillator when a person has 6 months to live is similarly not helping the patient at all. It's guaranteeing a painful death unless somebody has the courage to turn off the defibrillator.
We have come a very long way since the original Medicare statute, which has not been amended in this regard, forbade Medicare to exercise any interference with the practice of medicine. But we're not to the point, nor do I think the point, where evidence-based medicine is strong enough to permit an administratively feasible system of oversight of very complicated care decisions. And I think the issue of expensive interventions in people whose probability of life expectancy is relatively short is probably the last thing the federal government is capable of rationally managing. I think that may be too bad, but at the end of the day, the whole Medicare system, the whole system of health insurance, public or private, has to be built on the assumption that most doctors, most of the time, and most other clinicians, most of the time, are trying to do the right thing. If you don't build that into the system, it can't operate at all. And to the extent that the medical community and the clinical community believes that in the case of terminally ill patients, that's not true. That community has to solve it and stop blaming it on the payers. If there are people who are doing things, if there are physicians at your hospital who are doing things that harm patients because of greed or for whatever other reason, and you're permitting that to happen and you're not moving to take away their privileges, don't blame it on Medicare.
What we really need to talk about and should be talking about is culture change. We shouldn't be focused on institutions and institutional change and rulemaking, but it's going to take a culture change within the population and a culture change within the system coming together to change what patients demand so that they know to express their goals of care and so that the system is ready and able to, and that's an expectation that our system will respect the patient's wishes.
Absolutely.
Bruce's cynicism and forcefulness helps my blood boil. The time has come to stop being so pussyfoot around all this stuff. Yes, the person who comes to the hospital 3 times with COPD and doesn't have an advanced care plan, that's a medical error. It should be reported like a wrong surgery. I mean, we should start getting tough about these things. And we can start with simple ones like that, and we can start with, denying some privileges. But we also need to encourage the community to be really outraged with the, fill in the blank, they've been being dished up. I mean, we keep papering over it. We keep, one by one as we talk with patients and families, we'll make this get kind of right. Yeah, but let's also tell the families to raise holy hell at the end of all this and to go to their congressmen and go to their senators. We need an act up for old people. We need people in the back of the room here painting posters. We need people getting really mad about what we're being dished up because, frankly, guys, we're going to be bankrupt in 2030 if we don't figure out how to take care of one another at a cheaper price better. And the only party to the system that could do it is to get the public angry. Because all the parties that now have the power and that now get the money and that now, are kind of drifting along are perfectly happy to let it keep drifting and let the IOM put out a report and let us sit around, politely talking. And we aren't changing anything because the only way it seems that we can actually change the power of relationships is to get the public so angry that they fire us.
Yay. So we need a raging, aging, or a Gray Panther movement, and I think we have our spokeswoman.
Dr. Friedman, I'm an emergency physician from Florida. I just wanted to make a comment. You made a comment earlier that payment incentives haven't worked in the quality program. I would suggest to you that payment disincentives have not worked in the quality reporting program, but that payment incentives in general do work to change providers' behavior in positive ways. But disincentive programs typically do not. And
I just, we don't have the time now, it's not the place, but I could cite you 30 examples. Sometimes incentives work and sometimes they don't. And we have a lot of experience and a lot of data, and I can cite you 30 examples from personal experiences. Sometimes they worked and sometimes they don't. If you want to get home care physicians, or you want to get physicians to manage home care, and you raise the fees for home care management and expect them to actually pay more attention to home care cases, they won't. We have empirical experience to that. If you want to pay surgeons if you want to pay dialysis centers per unit for EPO administered for treatment of anemia, you'll find out that every dialysis patient in the United States is anemic and is getting a maximum unit of EPO. It depends. It depends on who the providers are, what the circumstances are, what you're paying them for, and how much you're paying. And that's the empirical case. And everybody's got an anecdote, but if you look across a wide range of anecdotes, sometimes it works and sometimes it doesn't. And understanding why it does and why it doesn't is actually the relevant question, I think, in many cases.
Over here.
Oops, sorry. I'm Mariel Harris. I'm a geriatrician and hospice and palliative care physician, and I've served as a hospice medical director and initiated a palliative care consult service in a nursing home where the hospice was based. And I'd like to make a couple of comments, and one is back to something that was underscored earlier, and that is that the advanced directive forms that are used, at least in the states that I have worked in, are very unfriendly to the people who are trying to read them and who are supposed to be able to execute them without the help of a trained professional. And even the ones that have spaces in them for people to write in, I worked in Ohio for many years, we changed our advanced directive. We got a place in there for people to write their wishes. I never saw anybody write anything. And all the geriatric patients that I ever gave the forms to and sent them home and said, come back, bring your family member after you've had the discussion at the dinner table. We'll go over it in the office and I'll help you get it signed. No one ever brought them back. So we actually did a study to see whether or not if we rewrote the forms in 8th grade language with the help of a literacy expert, if anybody would find them easier to fill out. And people are really hesitant to tell you how little they understand of the information that you're providing them. So palliative care has taught us to listen to the patients, but I think we also have a duty to go back to our legislators and whoever created these forms, and whether we go with Dr. Bomba's approach, which I think is great, to have people be able to write their own desires out. We have to help them, but we also have to make the forms more user-friendly. And my other observation is that in the nursing homes, the patients that we accepted in our hospice were the ones that were not getting adequate care based on the services that the nursing home was paid to provide, the staffing for those patients. And the ones that we had to discharge from hospice really sometimes within hours to days became much more seriously ill because the hospice was actually making such a huge difference in the quality of the care they got. And I think unless we unchain the nurses so that they're not at their carts passing out meds, and allow them to go back to their bedside activities, which is why they went into nursing, and let them do the great communications that they are capable of and want to do, we're going to have a terrible time in nursing homes, because we have somehow lost the way in the way we regulate the nursing homes. I know some of you have said that nursing home care is inadequate, but part of that is because we have created the wrong incentives in the nursing home. Thank you. Thanks for this great conference. It's been awesome.
Did you want to speak
I have to share my own story, or my own family story about this, and it's sort of the opposite problem with advanced directives, but this is the true story of my then 85-year-old mother-in-law, 3 days after discharge after a valve replacement, a cardiac valve replacement, and hospitalization slightly prolonged by some of the expected sequelae of that procedure, including a minor stroke from which she had largely recovered, but she hadn't totally recovered, which became the justification for her getting home care. But all her cardiac symptoms at the time were fine, and so on and so forth. When the visiting nurse shows up 3 days after discharge, or 48 hours beyond the legal limit, but we didn't go into that, introduces herself and then says, Mrs. Wellen, my name is so-and-so, it's nice to meet you. Have you filled out your advance directive yet? The amount of time and energy it took to get my mother-in-law back to sort of a reasonable psychological state, because she didn't think she was dying until she was, and because she wasn't. She wasn't in any immediate peril, but when she was asked that question, she assumed she must be.
This is why the committee envisions a life cycle planning effort.
Well, this is why it's really about a conversation. It's not about a form, it's about a conversation and a relationship.
Absolutely.
And what happens is you give health professionals working in inadequately managed organizations a form, and they'll shove a form in front of people's face.
That's why we envision change. So,
and
that's why David was going to speak to some of the nursing
I just want to say
homes.
something briefly to the nursing home point, so we can get to the last questions. You raised precisely the dilemma, that we face in thinking about whether hospice, needs to be a separable thing for nursing home residents. Is that hospice provides, essential services for so many people in nursing homes. It wasn't there initially. Hospice didn't initially include nursing home residents. It was only added in 1989. Now around a third of hospice enrollees are in nursing homes. And the challenge is that a lot of the hospice agencies that serve high numbers of nursing home residents don't provide the type of care we'd all like them to. And so there's this tension between wanting residents to have high quality end-of-life care that hospice has contributed to, and wanting to be more efficient from a program perspective and hold nursing homes accountable for the care they provide, including end-of-life care.
I think we are going to fit in one more question.
Great. My name is Jethro Heiko. I'm a partner in the Action Mill. We run a platform called Common Practice. We believe that everyone can get better at conversations about end-of-life and mortality, and that by doing so, all our lives are enriched and our communities are more resilient and stronger. We're also designers of the game, My Gift of Grace. There's a lot of talk about culture change. We love culture change. My background includes nonviolent strategy, as does our firm. We're experts in culture change. We study it. So I invite you all to join our platform. But I also would love to engage you more in conversations about what culture change really means, because I think people don't always understand it. They talk about it. They don't necessarily study it. And so I hope you join us. We don't have all the answers, but we are eager to explore with others. And I'd say that from our perspective, practice, you get better with practice, and culture change actually at its root is all about the habits that you have every day. And since I was 20, I've been practicing talking about death on a daily basis. And I am, despite what you might see right now, a very joyful person. And I'm raising my children, they're 4 and 6, to talk about death on a regular basis. They have a lot of questions. I don't impose it on them, but they frequently raise it, and they're very curious. I played my game with my 6-year-old daughter, And I think that people have a lot more capacity than we expect, and our communities need us to meet them where they're at, and right now they're way ahead of us. So,
Thank you.
Thank you.
And
I think,
go ahead.
one of the things, I recently had the opportunity to play the game,
Yeah.
My Gift of Grace, and it's a great vehicle for having conversations in a non-threatening way, so that the first time you're thinking about this is not when someone puts an advance directive in front of your
Right.
face, but you're thinking about, what are the things that matter to me, and you're sitting in a room playing with a group of friends or colleagues and really having a discussion. So you're changing our culture from one that doesn't talk about death and end-of-life wishes to one that does and makes it part of the natural conversation. So I applaud the game, I enjoyed playing it, and I look forward to playing it again.
Thank you. And thanks to the panel for a robust discussion. And unfortunately, we're going to have now Dr. Zhao come and wrap up the conference
Why
for
is
us.
that unfortunate?
Because it's been a good day.